Hi everyone, welcome back to Beyond Your Knowledge. So today we're going to be studying about the George syndrome, and we're going to see some characteristics, how that works, and also about the Velocardio Facial Syndrome. But before we continue, I would like to share with you John 3:36, and says that whoever believes in the Son has eternal life. Whoever does not obey the Son shall not see life, but the wrath of God remains on him. Now, my question for you is, would you like or do you believe in the Son? Would you like or do you have the certainty that you have the eternal life when Jesus comes the second time? Okay. So keep that in mind, and let's just now talk about the George syndrome. Well, the George syndrome, we can mention that it is a genetic disease. So we can start saying that it's a genetic disease. What it is going to have a deletion of the, it's going to have a micro deletion, so in a certain chromosome. So which one do you think is going to be the chromosome? So the chromosome 22, microdeletion in the chromosome 22 Q 11.2. Okay, now this involves the deletion of the genes residing in this adjacent loci. Okay, now to learn a little bit more, probably we can go and do a table here. Okay, and probably I will open a new slide to show the table. So the table is about the George syndrome, and we're going to see the pathogenesis, and also we are going to see the clinical features. Okay, let's see. So in the pathogenesis, I think that we mentioned a couple points already, or basically we mentioned one of the points, which is the chromosome. I'm going to do this in blue better. Let's just do this better here. So chromosome 22q 11.2 deletion, exactly, is going to be micro deletion. Okay, now this is sorry, I just so the other one, it is the defective development of the pharyngeal pouches. Okay, so those two, this is that is going to be in the development of the pharyngeal pouches. This is going to be defective. Okay, now probably you're asking, what are the pharyngeal pouches? Well, we should figure out what it is that. So let's just figure out what it is. And so let me show you the picture here of the pharyngeal pouches. Okay, so but before we see the pouches, so the pouches, basically we have different of those. So first pouch, second pouch, third pouch, fourth and fifth pouch. The fifth doesn't exist. Okay, also there is another thing, the embryonic process, what is important that we should keep in mind is the cleft. Okay, the first cleft, the second, and the second, third, and the fourth clefts are right here. So basically it's all these here, the third and the fourth. So the first cleft is responsible for the external auditory meatus. The second, third, and fourth clefts, it is incorporated into the cervical sinus. Okay, now in the pouches, so remember that those pharyngeal pouches, all this, it is important in the embryologic development. Okay, And now those pharyngeal pouches form on the endodermal side between the pharyngeal arches, okay? And also the clefts or the grooves from the lateral ectodermal. So basically those clefts are from the ectodermal, and the pouches are from the endodermal, okay? Now those are from the embryologic processes. And so basically basically it is important to know that which one of those come from the first, second, third, and fifth doesn't exist, sorry, fourth and sixth. But now in this lesson that we were talking about here, we were talking about the DiGeorge syndrome. So the DiGeorge syndrome, which is this one that we are talking, say that the DiGeorge syndrome has a defective development in the pharyngeal pouches. So those pouches, they will fail, okay? So now I think that we can see the clinical features of the patient that has a DiGeorge syndrome. And okay, so I think let me just move this here, and we can have our room. Here we go. And then now clinical features. So what are those? That is a mnemonic, which is called catch, okay? So C A T C H, okay? Sounds like catch the money, but it's not catch the money, it's catch, okay? Cat CH. So the mnemonic cat CH, C stand for, I'm going to write it in blue, the other one. So the C stand for conotruncal cardiac defects, okay? So conotruncal, where cardiac, another C. So just put this in black too, and we can remember cardiac defects. So what are kind of defects this patient can have in the conotruncal defects? So for example, tetralogy of Fallot, okay? So tetralogy of Fallot, probably you're asking, but what it is tetralogy of Fallot? Well, we can learn, we can figure it out right now. So let's just first write it here. So the defects in the tetralogy of Fallot, for example, and then I will show you. So the tetralogy of Fallot we learn as a proof, okay? So we're going to see a picture here. First, I'm going to show you the normal heart. So the normal heart, basically your pulmonary artery go to the lungs, okay? Your aorta go to hold the whole body. Your right atrium is going to drain into your right ventricle. Your right ventricle is fine, and your left ventricle is okay as well. So that is oxygenated blood that flow into your left heart that come from your lungs, okay, which is here. And then the deoxygenated blood, so that come from the whole body into the right atrium and to the right ventricle. Now the patient that has tetralogy of Fallot, so what's going on with them? So basically, so we can learn as the mnemonic proof. I'm going to write it down in this corner here. So PROB, proof, okay? So P, because the patient is going to present with pulmonary stenosis. So basically you go and check the pulmonary valve, which is going to be right here, and it's going to be stenotic. So and then the patient has a partial obstruction, so that means a stenosis of this right ventricular outflow to the lungs, so and the pulmonary valve. And then this is going to cause, so because there is an obstruction in this pulmonary valve, or in this or in the, and when go to the lungs, and the way to the lung that has stenotic and has has the way is difficult to go through, so the right ventricle needs to do more effort. So what's going on with the right ventricle? Now comes the R, right ventricular hypertrophy. Okay, hypertrophy, so which is right here. Okay, so and if you go versus your right one, do you see how thin it is, but nicely the layer? But here is going to be basically too much more, it's going to be hypertrophic. Okay, now this is the right ventricular. Now probably you're saying, but that sounds, I can see it, but then the other one is to be in the O. So the O is for overriding of the aorta, and then what does happen is that there is an increased outflow in the aorta, okay, which is right here. Now then the patients, you know that we have the septum, which is basically the one that divide your this is the septum, just here, follow this. This is the septum. The septum is the one that divides your left ventricle from the right ventricle. Now this one has a defect, so ventricular septal defect. This is right here. And if you have a ventricular septal defect, so the deoxygenated blood is going to deoxygenated blood is going to mix with the oxygenated blood, and then it's going to be here a mix of blood. Okay. And yeah, so basically this is the pathophysiology of the tetralogy phalloid. Wow. Now DiGeorge syndrome has this tetralogy of phalloids because they have a conotruncal cardiac defects. But this patient not just only can develop tetralogy of Fallot, these patients can develop also another condition, which is there is an interruption of the aortic arc. Okay, so that means there is an interrupted aortic arc. Okay, so basically this is in the heart of the patient that has DiGeorge syndrome. Okay, now the other one in the clinical features of the patient that has DiGeorge syndrome is A, and A stands for abnormal faces. Okay, so that means that the patient, so their face is going to have some abnormalities. Okay, then T stands for thymic hypoplasia or aplasia. So that means that the thymus is not going to develop, which is aplasia, or is going to have a poor development, which is hypoplasia. Okay, or can have aplasia. Now, sorry, I should be doing this in blue. Let me just fix it that everything matched together. Okay, so yeah, just gonna write it in blue. Okay, that's fine. Well, we were mentioning that has a thymic hypoplasia or aplasia of the thymus. So, but first, what is the purpose of the thymus? The thymus, it is responsible to help you in the immune system producing your T cell. So now, if you have T cell, go TT for tissue, which is one of the cell-mediated system of the immune system. And now, but because the patient has an hypoplasia or the patient has an aplasia or the thymus, so that means that the T cell is going to be deficit. So deficiency of the T cells. Make sense? I hope that makes sense. So now the next one, DiGeorge syndrome. The other characteristic or the clinical feature that we are going to see is C. We have two C. We already learned one, which is conotruncal cardiac defects, which is going to present with tetralogy of Fallot, or is going to present with interrupted aortic arcs. So now the other C that we're going to see, it is a craniofacial deformities. Okay, so that means that you, again, so craniofacial deformities, and I think that we can connect a little bit with abnormal faces, but abnormal faces is more for your faces, but this one is a craniofacial, so that means the part of your cranium and the vision, so it's going to have deformities. So, but what kind of deformities can have? So the deformity is called cleft palate. So the patient can have a cleft palate, and now we can see another C here. Okay, C for Cleft palate, C for craniofacial deformities. Okay, now I will show you a picture of the cleft palate. Okay, so here we go. Cleft palate is here. So imagine a baby, a newborn with a cleft palate. So first, doesn't look that appropriate, or yeah, so something that is not comfortable in the parents and for the kids, because it's open here anteriorly, and also when you check in the palate, it's going to be open as well. Now imagine a baby trying to suck the milk. So and then the milk can go through here, and then the patients can develop infections, can develop different things, because there is this communication, that this opening. So this is a cleft palate. But the DiGeorge syndrome that has the microdeletion, the chromosome 22 Q11.2, so they can develop also this craniofacial deformities, cleft palate. And also they can develop one more thing, so that we can it is hypocalcemia. So this patient is going to have low levels of calcium in the blood, or they can develop as well hypoparathyroidism. Okay, so basically those are the main one, but there are a few more things that we're going to be talking about DiGeorge syndrome. So what else we can learn about the DiGeorge syndrome? So also we're going to open a new slide here. So the DiGeorge syndrome has an defective neural crest cell migration. So that means that there is a but probably you're asking, but what is can we talk a little bit more about neural crest cell migration? Yeah, so we can mention I learned this mnemonic and I would like to share with you. So it is called Motel Pass, MOTEL. Okay, so motel, and then we're going to hear pass, PASS. That looks like a 5. It's not a 5, it says. So there we go. It probably is better. So M stands for melanocytes. So all those derivatives from the neural crest cells. Okay, melanocytes. O is for odontoblasts. T is for tracheal cartilage. E is for enterochromaffin cells. So each time that you see a question and you identify any of those in the question, so now you know that come from the neural crest cell migration. Enterochromaffin cells, sorry. L stands for, L is for laryngeal. Laryngeal what? Laryngeal has cartilage, okay? Now cartilage, what if you're talking about collagen, so what kind of collagen it is? Is cartilage. Is collagen type 2. Okay, I just want to make the connection there. Then P, we have 2 P's, and one is parafollicular cells. Okay, then the other P, and we're going to put it here. I will probably put at the bottom that we can remember better, and we have more room as well. So the other P is for pseudo unipolar cells. Okay, so probably will be good to know pseudo unipolar cells, what does it mean. So remember, pseudo is false, uni means one, So basically, this is a kind of sensory neuron in the peripheral nervous system. Okay, so basically it's a neuron that is going to be in the peripheral nervous system to sense. Okay, and well, the other I mentioned, pseudo, false, uni 1, and this neuron also contains an axons that has split into two branches. One branch run to the periphery and the other branch go to the spinal cord. Okay, so basically that's, if you see, for example, they're talking about periphery and the neuron cells that which is sensory, and probably will give more clues, and they want to know the origin, and they mention neural crest cell. So well, we already know that it is pseudounipolar cells. Well, then we continue with the mnemonic, so with those two P's, and then the other one is going to be A. Okay, and then is for all ganglia, is one of the A's, all ganglia, and then we'll have one more A, and then the other A is going to be adrenal medulla. Okay, so not the adrenal cortex, not the adrenal medulla, because the adrenal medulla is considered so the adrenal medulla, which is more the inner part of the adrenal gland. Okay, so, and then the S is for spiral membrane. Okay, so basically this is a motel pass. This is the mnemonic for neural crest cell. Now we can come back again to our Dijorch syndrome. So when they have a defective in this neural crest migration, and so this neural crest migration is derivatives from where? So let me just do this here. Okay, yeah, so this one is going to be, this neural crest migration is derivatives from the third and the fourth pharyngeal pouches. So it is a derivative from the third and the fourth pharyngeal pouches. So you remember that we saw a picture before the third and fourth pharyngeal pouches and others, so but except the number fit because it doesn't exist. So we can come back again to that one. So basically here the third pharyngeal pouches, the fourth and the sixth pharyngeal pouches, the third is responsible for the thymus. Do you remember that the patient that has a thymic aplasia or hypoplasia? But there we go. So because third pharyngeal pouches. Also, do you remember that we mentioned that the patients can develop hypoparathyroidism and hypocalcemia? So what do you think if we see that the fourth pharyngeal pouches and the sixth pharyngeal pouch is responsible for the development of the superior parathyroid? Now, if that is a failing in one of those pharyngeal pouches and the patient has the other characteristic that we mentioned right here, so the patient has the Dijorch syndrome. So those are the connection. So it is important that we keep in mind that. So let's just come back again to the third and to the fourth pharyngeal pouches. They are defective, and because there is no crest cell migration which is failing. Now, what else we can mention about this? So these results, so I'm going to open a new slide here. When you have all those things, the pharyngeal pouches, they're failing, so with the maldevelopment of the thymus, and then the patient can have a parathyroid problems as well as a subsequent T-cell deficiency and hypocalcemia, as we mentioned before. So we mentioned also the tracheal follow-up, Now, the dysmorphic facial features include the orbital hypertelorism. So we're going to talk a little bit more. So in the facial, so we saw here in the table that the patient can craniofacial deformity, cleft palate, or the patient has abnormal facies. But let's just go a little bit more and give some more information about this. So that is an dysmorphic, okay, that is an dysmorphic facial features. And what does that include? Okay, that include hypertelorism. Probably you're asking, but what it is hypertelorism? So basically, it is an abnormal distance between the eyes of the patient. And so let's just see a picture here. So basically, you can see here the abnormal distance between the eyes of the patient, just right here. Okay, so what else does the patient with DiGeorge syndrome can present? Well, also they can have a short palpebral fissures and a short philtrum, cleft palate, and bifid uvula. Okay, so let's just so short palpebral fissures, okay, so also and a short philtrum, okay, yeah, okay, so sometimes handwriting is not the best. Cleft palate, but it's okay. So at least we hope that everything is clear. And also bifid uvula. So all those the patient can have it. Okay, now if we are going to do, so let me pretty fast show you a picture of those that we described. Yeah, so here we are going to see the bifid uvula. Okay, this one. In this other picture, this one, you can see the short palpebral fissure, which is the distance here, so it's going to be shorter than usual. And also the other one is the cleft palate that we already saw before. And the patient is going to have also a short philtrum. The philtrum is this area here, but it's going to be short. Okay, sorry. So now this area here, which is the philtrum, is going to be short. Smooth philtrum, no, just this is Velocardio syndrome. This Velocardio syndrome. Okay, so but yeah, basically you can see here also the philtrum is going to be short because the patient has a cleft palate. Well, yeah, so that's, I think that basically with the picture is just like that. Now let's just talk a little bit more about the test. So what is the gold standard for the test? So the gold standard test is called fluorescence, the fluorescence. Okay, yeah, actually this is yeah, this is here, yeah, fluorescence in situ hybridization. Yeah, so basically why would we do the one? Well, basically this fluorescent in situ hybridizations, which is the gold standard, the genes of interest are hybridized with a fluorescent label in the DNA probe. So we're going to hybridize the genes that we would like to check. Okay, now if you don't have the lack of the fluorescent signal, that means that the patient has the microdeletion. How I know it? So well, because the fluorescent signal lacked is indicative of microdeletion. So, and then we'll see that which is going to be, remember which one is the chromosome? Yeah, going to do Q11. Okay, so I think that basically this is all about the DiGeorge syndrome, and remember that we can do all things through Christ strengthening us, and overall, so we can continue and being a good doctor in His name. God bless you all.